Good afternoon. I'm recording this because I know people are busy, but I think the things that I'm going to read to people here now are important. And I know people maybe don't have time to sit down and read a report, but I don't have time to make a podcast. So I'm going to put a little trigger warning at the top of this that it's about bullying in healthcare. And I know that you all know how to look after yourselves, that if you're distressed or you're not feeling so good, to let somebody know. This is about the harms and the risks and the impacts of bullying in the organisational culture and what should happen now. So there's 3 or 4 pieces to this. There's a discussion paper that I want to read to you. I'm then going to review what was said by Father Brian Darcy and Dr Declan Bradley regarding concerns. And there's a brief review of some extracts from an article about public inquiries, patient safety, and learning from that. So this discussion paper is about organisational culture, and particularly in neoliberal ideology. Don't worry if you don't know what that means, but it's about the continued existence of incivility and bullying within healthcare institutions. So what is known? Incivility and bullying in healthcare continue to persist despite their detrimental effects on healthcare organisations, employees and patients. Organisational culture plays a crucial part in the development or prevention of incivility and bullying. The association of neoliberal principles with incivility and bullying behaviours in healthcare institutions have been insufficiently scrutinised. What is new? The neoliberal agenda of healthcare reforms has allowed incivility and bullying behaviours to persist due to increased productivity demands, resource conflicts, and employee dissatisfaction. The concepts of deregulation, austerity, and individualism regarding the importance of employee policies and programs to mitigate incivility and bullying in healthcare institutions. The understanding of healthcare resources has resulted the underfunding of healthcare resources has resulted in denial and acceptance of incivility and bullying in the workplace, particularly in nursing. Introduction. Despite decades of multiple research studies proving its detrimental effects, incivility and bullying remains common in many workplace environments. Even healthcare institutions that are established on the practice of compassion and care and a strong code of ethics are not spared from this workplace violence. Many organisations have policies to address workplace violence. However, research has found these policies are unclear and ineffective in eradicating workplace incivility and bullying among healthcare professionals. There are numerous factors that influence the continued existence of bullying in the workplace, particularly in healthcare. This includes organisational cultures that permit bullying behaviours to flourish by accepting and denying their existence and creating norms that promote occupational inequality. Furthermore, the healthcare regulations influenced by neoliberalist ideology with a predominant focus on profit disregard the accountability in healthcare institutions and systems to address this issue. Nursing is the largest occupational group in healthcare and possess the greatest influence on the existence of the negative behaviours, which highlights the importance of nursing professionals in eradicating this issue. While there are a myriad of forms of incivility and bullying, the outcomes associated with such behaviours are singularly negative. The purpose of this discussion paper is to emphasise the importance of stopping incivility and bullying behaviours in the workplace, explore how organisational culture and neoliberalist ideology lead to the continued existence of incivility and bullying in healthcare, and provide recommendations for policy, practice and research. This paper will only refer to the incivility and bullying behaviours of professionals employed as in healthcare institutions, excluding violent behaviours demonstrated by some patients in the workplace. Background. Workplace violence is a major source of stigmatisation, discrimination, conflict and inequality in the workplace that regularly affects the dignity of many employed people worldwide. Incivility and bullying are the most prevalent types of violence that occur in the workplace. Incivility is defined as low intensity, deviant behaviour by the perpetrator with the ambiguous intent to harm the victim and destroy mutual respect in the workplace. Uncivil behaviours may include intimidation, discourtesy, and rudeness. Bullying behaviours are more robust, with higher intensity, longer duration, and increased severity than uncivil behaviours. Bullying is defined as negative, repetitive, aggressive, and intentional behaviours that may involve personal attacks, belittlement, threats, intimidation, exclusion, isolation, or humiliation. A major distinction between incivility and bullying is that uncivil behaviours can be one-at-a-time occurrences, whereas bullying behaviours are repeated and must occur at least weekly for a minimum of 6 months. The World Health Organization identified incivility and bullying as a silent epidemic which poses a major public health concern and demands immediate intervention. It is reported that 50% of employees globally experience workplace incivility and bullying from their superiors, colleagues and subordinates. However, the true incidence of incivility and bullying behaviours is presumed to be higher due to unrecognised and unreported cases in the workplace. According to the Canadian Centre for Occupational Health and Safety, incivility and bullying are occupational health and safety hazards that negatively affect both civilians and institutions. It was found that the majority of reported workplace incivility and bullying occurred in healthcare and primarily involved professional nurses and doctors. Furthermore, a recent study in developed countries revealed that 45% of healthcare employees have been bullied, and 39% of health professionals witnessed bullying behaviours and were at heightened risk of psychological stress. For these reasons, hospitals are categorised as one of the most hazardous workplaces. Organisational culture is the collection of beliefs, values, assumptions and practices that shape the unique social and psychological environment of an organisation. Research has shown that organisational culture plays a crucial part in the development or prevention of uncivil and bullying behaviours. The presence of incivility and bullying are found in organisations that ignore, allow and practice these negative behaviours. Neoliberalism is a political ideology that advocates for the market to foster economic growth and innovation. The neoliberal agenda supports deregulation, austerity, privatisation, capitalism and individualism. Neoliberal policies place limits on government spending, regulation and public ownership. The adoption of free market approaches has resulted in an increase in inequality and an underfunding of healthcare resources necessary to ensure safety. Neoliberalism places a greater emphasis on the quantity of health services rather than the quality of patient care and employee satisfaction. A few of the identified issues arising from this political ideology are a lack of accountability of organisations, the creation of highly stressful workplaces and social inequalities. Although these are identified to be precursors to workplace incivility and bullying, the effects of neoliberalism on these negative behaviours in healthcare continue to be underexplored. To elaborate on the significance of this issue, this discussion paper begins by outlining the impacts of incivility and bullying in healthcare institutions, employees and patients. This is followed by an examination of organisational culture and neoliberal causations that lead to these behaviours in healthcare. A conceptual map illustrated below in Figure 1. Lastly, recommendations for policy, practice and research to mitigate incivility and bullying in healthcare institutions is presented. This discussion is informed by a review of literature and encourages nursing professionals and leaders to explore the current political climate affecting healthcare and their critical role in resolving this. The effects of incivility and bullying in healthcare. Healthcare is a dynamic, complex and often stressful environment and is primed for incivility and bullying behaviours to occur. Multiple research studies have repeatedly indicated the detrimental effects of incivility and bullying in the workplace. Healthcare organisations are not immune to the negative effects of such behaviours. In fact, incivility and bullying more frequently occur in healthcare than any other industries. This may be partly due to the highly stressful environments and physically limited workspaces that are more likely to lead to negative behaviours. The damaging effects of incivility and bullying are widespread and can negatively impact healthcare situations, its employees and patients. Impacts on institutions. Uncivil behaviours can lead to significant impacts and expenses for healthcare institutions. For example, an institution could be impacted by an increase in employee absence. It has been reported that 25% of victims and 20% of witnesses intended to resign due to uncivil or bullying behaviours. The absence rate, leaving rate that occurs from workplace bullying alone is 20%, furthering the severity of the current healthcare provider shortage. Employee absenteeism, stress leave and injuries as a result of bullying could increase the operational cost of the institution. Employee turnover could affect the institution's financial performance due to the separation, replacement and training costs. Customer service disruption and underperformance of bullied employees could further lessen the productivity performance of the institution. Moreover, it is estimated that unresolved bullying incidences may lead to lawsuits and could cost the institution up to $30,000 per case, increasing to $60,000 if the case goes to court. Those obviously are American figures. Although the increase in public awareness about bullying continues, more than 72% of organisations deny, discount, encourage, or rationalise or defend bullying behaviours in the workplace. Many of these institutional impacts are related to employees that are victims of bullying. Impacts on employees. Healthcare professionals are more likely to experience workplace incivility than employees in other sectors because of the demand and the pace of the work environment and the emphasis on performance. Research shows a common belief that workplace bullying is part of the job and that healthcare employees accept it as a routine occupational hazard. The risk of healthcare employees experiencing violence is estimated to be 16 times greater than other service workers. The impacts of bullying on employees' job satisfaction, emotional health, and social well-being create significant damage. Many victims experience a loss of meaning derived from work, an inability to focus, a sensation of dread at the very thought of going to work. Victims express feelings of exclusion, isolation, intimidation, belittlement, and humiliation. Bullying damages the victim's professional identity, resulting in limitations of career opportunities and chances of job promotion. Moreover, there are psychological and physiological effects of bullying that are difficult to ignore. Some physiological effects of bullying include insomnia, gastrointestinal discomfort, musculoskeletal problems, hypertension, chest pain, palpitations, headaches, and worsening of chronic illnesses. The psychological effects of bullying victimization include anxiety, phobias, panic attacks, depression, loss of libido, post-traumatic stress disorder, and suicidal ideation. The stress caused by workplace bullying has the potential to affect the victim's home life, including family, childcare, and social relationships. Victims also suffer from financial issues due to the absence or loss of their jobs. Healthcare employees have not reported bullying behaviours for various reasons, including but are not limited to productivity demands, hierarchy, and loss of control. As a result, accurate data about workplace incivility and bullying is non-existent. Workplace violence does not exclusively affect healthcare institutions and healthcare providers, but it also not only affects them, but also indirectly impacts the health of their patients. The impact on patients. Workplace incivility and bullying has been acknowledged as a hindrance to the delivery of high-quality patient care and threatens patient health outcomes. These behaviours traumatise the workforce and grossly impact patient quality and safety. Many bullied healthcare workers reported knowing medical errors, malpractices, procedural violations that resulted from disruptive or bullying behaviours. Patients of bullying physicians had 14% more complications post-operatively than those patients treated by surgeons exhibiting positive behaviours and professional manners. It has been revealed that 94% of professional nurses felt that bullying behaviour had negative impact on patient outcomes. I'm going to read that again. It has been revealed that 94% of professional nurses felt that bullying behaviours had negative impacts on patient outcomes, and while 54% state that patient safety was at risk. Patient safety issues may be related to how bullying is perceived, causing a decrease in staff motivation and commitment to their employers and the ability to concentrate on the job. These place employees at greater risk of making practice errors. Medical errors are the third leading cause of patient deaths in high incidences directly caused by poor team communications hampered by workplace incivility and bullying. Organisational culture. Organisational culture is often cited as a factor contributing to the emergence of incivility and bullying behaviours. Researchers believe that the precursors to continued existence of workplace violence are found in the cultures that misuse power, disregard equality, and facilitate oppression. Some authors view bullying in healthcare environments as a direct reflection of power imbalances that originate from the hierarchical structures existing in many institutions. Those individuals at the top of the hierarchy possess the power to bully their subordinates solely by virtue of their position. Unfortunately, perpetrators have been associated with traits such as being powerful figures in the workplace with the ability to manipulate the distribution of resources. Experts in their fields of practice have strong personalities and possessing control over organisational functions. Whether it is exercising power of authority or misusing hierarchical structure, some physicians, healthcare administrators, nurse managers and supervisors have been known to bully their colleagues and subordinates. The existence of power disparity between bully and victim makes it difficult for the victim to bring conflicts to compete and successful resolution. For many employees, income and job security are important. Reporting on civil and bullying behaviours of their superiors may result in wage or job losses. Since many perpetrators are in a position of power, there may be a culture of acceptance and denial that such negative behaviours in the workplace, and these add to the reasons why many healthcare professionals remain silent and choose not to report bullying behaviours and violent acts perpetrated by their superiors. Many experts believe that all forms of bullying stem from power that is misused and that dysfunctional power dynamics can root itself in an institution and become a cultural norm. This may be one of the reasons healthcare has among the highest incidence of bullying as opposed to other sectors. Bullying behaviours build on existing embodied, classed, gendered, radicalised, sexualised social inequalities, making people accept such inequalities as part of the normal daily living. There is evidence to suggest that certain individuals or groups are highly vulnerable to occupational inequality and maltreatment due to exploitation, marginalisation and cultural imperialism. The minority gender in a workplace is more likely to get bullied, regardless of their sexual organisation. Furthermore, marginalised groups such as visible minorities, members of indigenous groups and employees in lower social classes are considered to be easy targets of bullying behaviours in the workplace. The creation of clique groups generates an opportunity for nurturing and hiding the bully. These social inequalities and maltreatment of such groups are highly common not only in healthcare institutions but many other sectors and industries. Most healthcare professionals have directly experienced or witnessed bullying in some form that may have resulted from occupational or social inequality. Silencing came from the belief that good nurses do not change the status quo and therefore silence themselves to avoid conflict. Some of the origins of bullying in healthcare can be explained by oppression theory. In 1971, it was theorised that oppressed group behaviours can occur when powerless or submissive and silent in confrontation with authority. Consequently, fear and low self-esteem lead to internalised anger and aggressive behaviours towards one's own group members. Historically, nurses in hospital settings were argued to be an oppressed group, as these settings were influenced by medical hierarchies and patriarchal structures in which nurses lacked power and control, thus heightening the vulnerability of nurses and other healthcare employees to workplace aggression. The culture of oppression in nurses is continuing to prevail in many parts of the world, particularly in developing countries. The experience of oppression may result in violence in a way as to achieve power over peers. However, incivility and bullying also occurs within and among other professions, and they can occur top down, bottom up, horizontally within any team or organisation. Although nurses and physicians are often considered to be the primary culprit of bullying, healthcare bullies can be any professionals who work in healthcare institution, including technologists, pharmacists, allied healthcare workers, ancillary personnel, administrator, and other non-physician staff members. Now, the next section in this report talks about neoliberal ideology, and I want to just explain a little bit about what that means. Neoliberalism is an ideology, it's a decision and an idea by the government to basically decide that the marketplace is the best solution, that if they look after corporations and corporate interests and private interests and, for example, private healthcare, that will be the solution. It is the opposite of what the NHS needs or should be. And we can see the privatisation of healthcare happening even in our local hospital, and a quadrupling of spending by the government into private healthcare, and the British Medical Association and others that are monitoring that can basically see that it is going to collapse the NHS. It's very expensive, and it also is less safe to privatise healthcare. But that's just one aspect of neoliberalism. Neoliberalism is also a decision to have poverty, a decision to have austerity, rather than tax the super rich. And you can see what neoliberalism basically boils down to is like a massive increase in inequality, so that people who used to be, basically lots of people are struggling, not just people on benefits, lots of people are struggling, lots of people in work are struggling. You can see that from the rise of food banks and everything. But all of neoliberalism is just an idea, and it's just an idea of the government. And there's definitely an alternative, and you can see that in reports from Oxfam, for example, who talk about the need to tax the rich appropriately, because all of the wealth is moving into the top 1%, and that's creating a growing inequality. And if you want to follow somebody called Dave's Economics and learn more about neoliberalism, that would be great to help understanding that, and we can talk more another time about what privatising healthcare means. If you want to see what happens, is just look at America and the hundreds of thousands of people who can't afford healthcare, and they're everywhere else in the world is trying to move to an NHS, but we appear to be going in the other direction. So we're going to talk a little bit now about this section about neoliberal ideology, which is recognised by the author of this report as contributing to the situation with bullying and incivility in workplaces. So neoliberal ideology. Neoliberalism is generally associated with policies aimed at achieving economic stabilisation through government deregulation, privatisation, decentralisation, and individualism. The neoliberal agenda of healthcare reforms includes cost-cutting for efficiency. Many developed countries such as Canada, United Kingdom, and United States have adopted austerity measures to reduce healthcare expenditure. Government deregulation has undermined healthcare through financial cutbacks and new approaches to healthcare management. Hospital leadership have adapted management strategies to make hospitals more efficient by reducing the number of nursing staff or by increasing the number of their patients to provide care at the lowest unit cost. This approach has led to inadequate skill ratio of staff to deliver effective healthcare services or monitor patients, resulting in healthcare employees' excessive workloads, de-skilling, burnout, and basically leaving. And as a consequence, incivility and bullying among health professionals have remained and progressed due to increased productivity demands and resource conflicts within the workplace. Furthermore, cost-cutting measures have resulted in limited employee resources and support programme for bullying, which may have resulted in the acceptance of incivility and bullying behaviours as institutional norms. Employee education programmes and anti-bullying campaigns are less of a priority for many of these institutions, as they make no significant profit through these programmes. Many hospitals are hesitant to terminate any staff that would result in difficult to fill vacant positions. Replacing employees with specialised skills, such as nurses and physicians, is daunting, time-consuming and costly. It's estimated that workplace bullying costs an organisation roughly 10% of their profits, forcing organisations to deny and ignore its existence. Capitalism and austerity have precipitated an underfunding of healthcare resources that have resulted in a myriad of safety issues among healthcare employees and patients. Moreover, deregulation has resulted in healthcare institutions' lack of incitement to take responsibility for the damages they caused. Neoliberal principles have promoted organisational culture's misuse of power by allowing frontline leaders to deliberately engage in bullying as a management style to increase compliance and minimise the complaints of employees. Nursing administrators and managers that highly value economic gains have a tendency towards uncivil and bullying behaviours. Such a management style creates workplace environments where paternalism, fear, and intimidation are pervasive. This type of workplace environment challenges the ability of employees to maintain their professionalism. Therefore, some participate or submit to such negative behaviours. In some hospitals, legitimate concerns and warnings raised by professional nurses are not always treated equally as those raised by physicians. The existence of authority gradients and power imbalances between healthcare professionals help condone workplace inequality, incivility, and bullying. Neoliberal individualism refers to the belief that the focus of attention with regard to healthcare and health policy should be on the individual rather than on the environments and societal institutions or structures. This principle disregards the environmental and organisational factors that result in uncivil and bullying behaviours, leading to employees being blamed. This gives priority to individual responsibility and choice over concepts of the public good. Workplace incivility and bullying and the lack of policy and programmes to address them appear deceptively insignificant in this political ideology. Nursing employees and leaders must recognise their professional responsibilities to ensure a safe work environment are far more important than financial or managerial agendas. Incivility and bullying resulting from organisational culture and neoliberal ideology are undeniably present in many healthcare institutions. The concept map presented in Figure 1, which you can't see, outlines the organisational cultures that misuse power, ignore social inequalities, and facilitate oppression, permit uncivil and bullying behaviours to occur. Moreover, it illustrates how neoliberal concepts of deregulation, austerity and individualism may have allowed these negative behaviours to continue and greatly affect healthcare institutions, professionals and patients. Now, recommendations. Policy. Non-violent forms of workplace aggression, such as incivility and bullying, are not illegal. Therefore, it is critical that healthcare institutions develop robust anti-bullying policies to prevent these behaviours. Although accreditation and regulatory bodies recognise the widespread danger and have implemented practice standards and guidelines to curtail bullying behaviours, organisations have been quite slow to adapt. The development of anti-bullying policies to reduce the chances of violence and to build in a positive workplace culture would be beneficial if they are strongly enforced. Healthcare institutions should distinctly state their stance about zero tolerance for incivility and bullying and provide anti-bullying policies that include clear definitions, explanations, reporting methods, consequences for violations, and anti-retaliation provision. To build a policy that will help create an anti-bullying culture, it is crucial to involve actions that will help address the issue when it arises. Such policy should at least include the following: conducting a thorough investigation when bullying is reported, encouraging immediate reporting, ensuring retaliation does not occur, providing training for managers on handling incivility and bullying behaviours, and enforcing policy. Practice. Changing the overall culture at organisational level is essential to prevent and end workplace incivility and bullying. Nurses and physicians can set the stage for addressing workplace incivility and bullying by examining and addressing their own behaviours and modifying practices that might be construed as such behaviours. It is essential to foster an environment that encourages open communication and collaboration. Moreover, healthcare leaders should hold all employees accountable for their behaviour and follow the code of conduct consistently and fairly for all employees, regardless of their professional discipline, position or seniority. To eradicate uncivil and bullying behaviours in the workplace, it is crucial to establish a system of high institutional responsiveness to bullying. This can be done by assembling an interprofessional committee to address unprofessional behaviours. The committee should collaboratively work to develop interpersonal relationship skills and education to effectively address unprofessional and violent behaviours. Additionally, nurse leaders need to be educated and trained to recognise and address bullying behaviours within their respective practice areas. Healthcare institutions must develop and implement reporting processes to formally document workplace incivility and bullying incidences. Reporting procedures must be clearly defined, quick and simple. It is essential that employees are informed about available reporting options, as employees who understand the reporting methodologies are likely to report and document incidents. Victims of bullying must be reassured that the reports will be investigated and kept confidential upon submission. All this in turn would allow incivility and bullying to be recognised and addressed in a timely manner. Furthermore, organisations need to determine why incivility and bullying is not reported and encourage the reporting of such negative behaviours. Departmental leaders should document all attempts made and actions taken to address bullying and other unprofessional behaviours. Research. Bullying goes by many names, such as workplace aggression, indirect aggression, interrelational aggression, workplace violence, vertical violence, horizontal violence, and incivility. In the literature, many of these terms are used interchangeably, and researchers have continued to proliferate constructs that label uncivil and bullying behaviours in the workplace, which adds to the challenges of building relevant literature. It's crucial that researchers and educators develop an agreement on a universal concept and definition rather than contesting the concept of incivility and bullying. Furthermore, researchers should focus on redefining the current technical definition of bullying. Bullying behaviours do not need to be occurring at least once a week for 6 months to be considered bullying. The detrimental effects of a single bullying incident could have devastating and lasting effects on victims. It is important to develop a standardised, valid and reliable measurement tool to quantify and document incivility and bullying in the workplace. The majority of literature reviewed focused on how perpetrators should be punished or disciplined. It is obvious that more research is needed on how to constructively and effectively confront and support perpetrators in ending their negative behaviours. Moreover, various interventions and violence rehabilitation programs need to be assessed for their effectiveness. Assessment of such programs should include costs and safety benefits to promote sustainability. The neoliberalism of healthcare has spurred normality in the form of institutional policies, management styles, and workplace culture where uncivil and bullying behaviour become part of the daily operations. To help identify and address the destructive consequences of neoliberalism, it's important that neoliberal concepts and principles should be explored within this context. Additionally, stress has been associated with these negative behaviours, and recent data has proven that frontline nurses experience a high degree of stress during COVID-19 pandemic, which negatively affected both their physical and mental health. An exploration of how the current COVID-19 pandemic and the resulting increases in stress, productivity, performance pressures, and resource conflicts affect incivility behaviours is warranted. Since nursing professionals account for 59% of global healthcare workers, they have potential to create a significant impact in resolving this issue. A lasting change in healthcare will only be achieved when incivility and bullying are addressed collaboratively by all disciplines and by the workforce as a whole. Conclusion. Workplace incivility and bullying within healthcare system are undoubtedly detrimental to the health of the organisations, the employees, and patients. It is critical that all health professionals, including nurses, participate in the resolution of this issue by ensuring a respectful workplace and a collegial practice. Nurse leaders and managers are in a prime position to address this prevalent issue by developing effective policies, promoting safe workplace culture, and utilising positive leadership skills. It is the responsibility of all healthcare professionals to build and maintain a healthy workplace environment that allows the provision of ethical, effective, and evidence-informed care. More importantly, nurses must have the courage to challenge the prevailing ideologies and understand what they mean to their organisations, profession, and patients. Now, this was written, we have to give credit to the people who wrote this, Micheal Guardia and Nelly Oelke. Now I'm going to read the words of Father Brian Darcy on the 30th of January 2023. He spoke at a meeting that was held in the Lakeland Forum in Enniskillen, and it was at a public consultation event when at the time that the Western Trust removed emergency surgery from the Southwest Acute Hospital. I work in hospitals every single day. I know how hospitals work. I have a lot of things that I am angry about. My anger is that our people have been betrayed. Our hospital was brought here because of medical science and because it was needed here. One of the things we are angry about is we don't seem to have a method of being heard. No matter what we say or what we do, the decisions are made. I'm glad you're here tonight consulting us. I wish you had done it a year ago before you made your decision. I've been asked to speak on behalf of the people who have asked me to speak because I'm in the hospital so often. It has been hinted here a few times, but it needs to be said. The morale of our hospital workers, nurses, consultants, doctors. In my 10 or 12 years in this new hospital, I have never seen it so low. They feel neglected. They feel bullied. They feel they do not have a voice. Nobody is consulting them about it, and they live in fear. That's why our consultants are leaving, because of the morale. I don't like having to say these things. I hope you are hearing what I'm saying, as I'm speaking on behalf of people who have asked me to speak. My own comment is this. What we are experiencing is a rundown of the best hospital that I have ever been in, north or south, private or public, and it seems to be run for consultants rather than patients. It is vitally important that your consultation now do what you promise, that you will keep us informed and look at two things. Your own style of management, because you need to look seriously before you make any decisions. You need to look seriously at the style of management of our hospital. I'm now going to read some of the words that were written by Dr Declan Bradley from Queen's University, who was working for the Public Health Agency at the time that of the Pathfinder project that happened. It was initiated in, I think, 2018, which would have been 6 years, just 6 years after the Southwest Acute Hospital actually opened. And at that point, it was questions raised over its sustainability and a wish by the Western Trust to rearrange and find new paths for services, because they wanted to not need any locums in the Southwest Acute Hospitals, and there were lots of reasons why the Southwest Acute Hospital needed locums, but we won't go into that today. Dr Declan Bradley wrote on some of the frustrations that the staff had reported as part of the Pathfinder project. Staff had reported that there were a major frustrating problem with the effectiveness and efficiency of recruitment to jobs within the trust. There was a frustration that culture was always reacting to problems and not preventing them. A concern that management was too remote, that there were worries that staff and nurses were leaving because they do not feel listened to. Worried that staff were weary and tired, and raising expectations will backfire. Worried about poor communications between teams, departments, hospitals, and between trusts and primary care, affecting continuity and safety of care. Irritation at the micromanagement of staff. Worried about recruitment and retention of staff. Concerned at an over-reliance on expensive agency staff. Concerns that complaints process takes too long and that nothing is learned from it. And concerns about the amount of sickness absence, possibly due to stress. I'm now going to read some extracts from an article from the Future Healthcare Journal, and it's written by Helen Hughes, and it's about public inquiries, patient safety, and the implementation gap. So I'm just going to take some key extracts from this because I think there's a few key parts that are important. So Helen writes, and she says that a decade on from the Francis report, avoidable patient harm continues to occur and we have continued to see new inquiries and reviews into serious patient safety scandals. A failure to listen to patients or to learn from previous investigations, a corrosive blame culture, a lack of effective leadership, and an unresponsive regulatory framework are alarming and often reported themes that we review here. And this is written in 2023. On the 6th of February 2013, the Mid-Staffordshire NHS Foundation Trust Public Inquiry was published. It was chaired by Sir Robert Francis QC. It detailed a series of major patient safety failings and causes of avoidable harm at the Trust between 2005 and 2009. A decade on from this inquiry, avoidable harms continue to occur. We have continued to see new inquiries and reviews into serious patient safety scandals, such as Morecambe Bay, the Independent Medical and Medical Devices Safety Review, and the Independent Review of Maternity Services at Shrewsbury and Telford, to name just a few. And she does have a complete list of reviews that had key patient safety inquiries and reviews in England. Burswick, Morecambe Bay, Liverpool Community NHS Trust, Infected Blood Inquiry, Gosport, Independent Inquiry into issues raised by Patterson, Maternity Reviews, Shrewsbury and Telford, East Kent Hospitals NHS Foundation Trust. She goes on to say that inquiries and reviews provide an opportunity to take a deep dive into the most serious incidents of avoidable harm. They provide an official record of events, identify points of learning, hold organisations to account, at least in theory, and make recommendations with the intention of preventing similar failings from occurring in the future. However, all too often, inquiries and reviews identifying similar problems have not led to significant improvements in patient safety. Often, one problem frequently highlighted is the persistence in corrosive blame culture in parts of the NHS, which leads to staff failing to report the actions that lead to avoidable harm due to the fear of personal consequences. Having an open and fair culture, on the other hand, can help enable patient safety issues to be raised, discussed, and addressed. The National Audit Office reported and noted that once inquiries have concluded, there is no central repository or responsibility across government for tracking whether recommendations have been implemented and ensuring that inquiries have an impact.